The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
I'm Ryan Hankins. I work primarily out of Georgetown in Washington, D.C. Georgetown University Hospital. It's affiliated with the MedStar Health System. And I specialize in a lot of aspects of urology, but a specific focus being men's health and erectile dysfunction. So today is mainly an information session to go over all of the options, or a lot of the different options that we have that we know work well for erectile dysfunction. So really we'll talk about what is it, who has it, how prevalent it is, and then what are the causes. All right, so erectile dysfunction, or the inability to achieve or maintain an erection that's satisfactory for whatever sexual activity, whether it's masturbation or intercourse. And really 1 in 5 men in America older than 20 years old have some form of erectile dysfunction in their life. It's very, very common. More than half of men over age 40 have some form of erectile dysfunction. And that really translates to millions. Over 39 million men are affected by erectile dysfunction in the United States. So I tell everybody in the office, I guarantee you are not the only one dealing with this. It's very, very common. So really we want to know, what are the different causes? The most common causes of erectile dysfunction are cardiovascular disease and diabetes. There are numerous medications that can also lead to erectile dysfunction. One of the important things when we see that cardiovascular disease in men leading to erectile dysfunction is erectile dysfunction in younger men. So men, say in their 40s, I usually tell them that it's important that they follow up with their primary care doctor as well, or even see a cardiologist, just to make sure that heart health is okay. Because one cause for erectile dysfunction is our vascular causes. And so as you see on the right, with the penile artery being a bit smaller than the main arteries that you see in the heart, you can have erectile dysfunction be actually a sign for underlying cardiovascular or other vascular abnormalities. So let's talk about the process. How does an erection happen? And then, so really the natural history, how does it work? So really with the penile anatomy, when you get aroused, the nerves stimulate the penis. And when the nerves stimulate the penis, you have relaxation of muscles that are in the penis. So a boner doesn't have bones. It's just a blood flow and fluid dynamics. So you have more blood flow in through the arteries. And what happens when you relax those muscles that are on the outside of the penis and the blood flows into the penis, it compresses the veins. So increased blood flow in and decreased blood flow out leads to really a pressurized cylinder. And that when you get that elevated pressure in the penis, you get an erection. It's that simple. Increased blood flow in, decreased blood flow out, so that you get increased pressure in the penis, and that gives you a nice, firm erection for penetrative intercourse. All right. The process kind of is the opposite when it comes to losing your erection. You actually get increased venous flow out, and you get what's called detumescence, or less firmness to the erection. So how do erectile dysfunction medications work? We use medications that work at a few different places along the whole erectile or ED cycle. So increases in blood flow to the penis help you achieve and maintain an erection. So we try medications to try to increase blood flow in, and then we use other things to try to decrease blood flow out. So who can treat erectile dysfunction? Lots of different practicing physicians can treat. Your primary care doctor, truthfully, I let all of the primary care doctors I know, they should feel quite comfortable treating, mild erectile dysfunction. And typically, inform them trying medications such as sildenafil or tadalafil, vardenafil. These are the oral medications we have, which we'll talk about. It's an easy thing to do in someone that's in good health to start them on oral medications. So family practice or primary care doctors, urologists are all specialized or can all do at least the early stages of erectile dysfunction. And then you have more specialized urologists that provide surgical options that we'll talk about with penile prostheses. These are typically prosthetic urologists that are specially trained to place penile prostheses. So these are available options we'll talk about, and we'll talk about them. Actually, in my practice, talk about them in a little bit different order, but the way we present them here are what we consider to be a little bit of the least invasive to most invasive, but we'll talk about all of them and how they work. Okay, so first, vacuum erection devices. So how does a vacuum erection device work? Really, it's a cylinder that goes over the penis, down to the base of the penis, and you have to have a good seal there. But you put the cylinder over the penis, and then it pumps up, whether it's a manual pump or the newest ones work with a battery-operated model that sucks negative pressure into the cylinder. That negative pressure allows blood to flow into the penis, and then when you have an erection, or enough blood flow in the penis, you take a silicone band that these come with, and you put that over the base of the penis. So it's like at the bottom of the cylinder. Once you have enough blood flow in, you just pop that silicone band around the base of the penis. These are nice because they work. It doesn't really matter what is the cause of the erectile dysfunction, whether it's arteries, veins, nervous injury. This works with any type of erectile dysfunction. And so these work quite well, but they do have satisfaction rate for patients is not as high as other options that we have. It's listed in the literature somewhere between 70 and 80%. But some of the things people don't like about them, they can be cumbersome to use with certain anatomy, such as large pubic fat pads. They don't always work as well. Sometimes the constriction band can be uncomfortable, or you can slowly lose the erection. So there are different reasons why patients don't usually like or continue just using the vacuum erection devices long term. Pills. Pills are one of the most common things we do. So we'll talk about these in detail. So the pills work great, and usually, honestly, the easiest first step in treating erectile dysfunction. And so they are effective in pretty much 75% of men, at least as an initial treatment. So the most common ones used are sildenafil. That's the original brand name's Viagra. So Viagra, or tadalafil, which is Cialis. There are a few others out there on the market as well. And these medications don't give you an erection. That's one of the most important things to know, is that these medications help prevent the breakdown of molecules that lead to you losing an erection. So you can't just pop a pill and expect something to happen. You still have to have the arousal or nervous stimulation from the brain, and so you still have to engage in some sort of foreplay, etc. But these enhance blood flow to the spongy tissue of the penis and to the erectile tissue, and they work very well for many men. They don't always work forever, though. So a lot of guys will start this, say, when they first develop erectile dysfunction in, say, their 50s or maybe 60s or whenever, and they work for a number of years, but don't always work forever. We tell patients that you cannot take them with or in conjunction with nitrates for chest pain, because it can lead to a severe decrease in blood pressure. So it is important that with any physician you speak to about starting these medications, you let them know about other medications that you take, especially cardiovascular medications. The most common side effects are usually some nasal congestion or headaches. Some people feel a little bit flushed after they take them, not everybody. They need to be taken at least an hour before you want them to work. So it takes a little bit of planning. And Viagra works, or sildenafil works best if you take it on an empty stomach. So those are some of the most common side effects. Tadalafil, a little different than sildenafil, can lead to a little bit of muscle cramping. Intraurethral gel we'll talk about next. This intraurethral gel is actually injected into the urethra. There's no needle associated with this, and there are some good things with this and some trade-offs. So it's a medication that you push into the urethra. I tell my patients it's very important that once you put the medication into the urethra, you kind of have to hold the tip of the urethra so that the medication doesn't leak out. And then you massage the underside of the penis to get the medication down the urethra. This medication helps, and it's typically compounded. It's two separate medications mixed together in this gel. And it's typically a medication called alprostadil and another one called phentolamine. And it can help you get an erection within 5 to 15 minutes on average. And it can be quite effective. The satisfaction rate is high. One of the most common side effects, or people don't like with it, is that it can cause some urethral burning. And obviously, your sexual activity is supposed to be fun, where burning is not a desirable side effect. You can usually improve that by urinating first, kind of coating the inside of the urethra with some fluid or urine, and then putting in the medication. I found that helps with patients. But that's really the most common side effect. Priapism is something we tell patients about with medications. Priapism is when you get an erection that lasts longer than 3 to 4 hours and starts causing pain. It is not as common as we see with, say, injections, but it can occur with these medications. Intracavernosal injections is what we'll speak about next. Now, with intracavernosal injections, the medication is injected directly into the penis. And this is the thing I tell patients about. I spoke to multiple patients today in the office about this specifically, is there's a little bit of a mental hump thinking about injecting your penis with a medication, but you're using a tiny insulin needle to inject medication directly into the erectile tissue of the penis. And it has one of the highest satisfaction rates of anything we can do for erectile dysfunction because it works satisfactorily in about 75 to 85% of patients. It's a mixture of multiple different medications. The most common ones are alprostadil, papaverine, and phentolamine. They work in a few different aspects of the cascade for erectile function to help give you erections. And then there's a fourth one called atropine that can be used as well. So there it comes in a bimix, trimix, and quad mix. So I know this is a bit of a busy slide, but what this just shows is that there are multiple different formulations. So when we teach patients in the office to give themselves injections for their erections, we titrate these medications. So there is no one size fits all when it comes to the injections. We want to find an injection that works for the patient, and we teach patients in the office how to give themselves an injection, and then we titrate to find them the right dose and what works well for them. These are injections that have to be given every time you want to have sex or masturbate, though. These are not an injection that necessarily fixes your problem. It is something that you have to do every time you want to have sex or masturbate. So with these injections, it's really the most effective medication that we have. And so success rates are quite high with these injections. So once we find a specific dose that works for somebody, the most common side effects are some bruising or pain at the injection site. Priapism is something that we do worry about. That's why we want to titrate to an appropriate dose for somebody. Priapism is where you have an erection that lasts too long. And so most common side effects are mainly pain and bruising. With long-term use, you can get some scar tissue that builds up, and which is considered almost like a Peyronie's disease that's been caused by something else. Most Peyronie's disease is it just happens naturally. The way these are stored, they're stored refrigerated, or at least refrigerated. Some people, if they don't use it very frequently, will just keep it in the freezer, but these have to be refrigerated, and typically you want to discard them on a monthly basis. Lastly, I want to talk about penile implants. And penile implants are, in my practice, we really try to work through all options for medical therapy before we talk about surgery options. However, once we get to the route of somebody that the available medical options don't work for them, then we talk about the surgery options. And this is what most guys call the Cadillac, honestly. And so really what a penile prosthesis or a penile implant, and there are a few different ones. The penile implant is an implanted device that is completely inside your body. And so there are a pair of cylinders that are in the penis. There is a pump that's in the scrotum, and then a reservoir for the fluid. So the penis is deflated when you're not using it. The fluid is stored in the reservoir when everything is deflated. And then when you're ready to have sex or masturbate, you squeeze the pump that's in the scrotum, and that pump will fill the cylinders that are in the penis. It takes about 10 to 15 seconds to do. So you pump, 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 pump it up. Once it's pumped up, it's rock hard, and it stays that way until you deflate it. I tell everybody in the office that just based on physics, air is compressible, but fluid is not. And these are filled with fluid. And so once you've pumped it up and it's pumped up and firm, it's pretty much rock hard like that until you deflate it down. It doesn't matter if you orgasm, it's going to stay pumped up until you deflate it. And we teach you in the office how to inflate it and deflate it after the procedure. These have the highest satisfaction rate of anything that we do for erectile dysfunction. And it really is the easiest thing when it comes to on-demand erections that last as long as you really want them to work. It does not interfere with ejaculatory function. So if you have ejaculatory function, it doesn't typically change. It will not bring it back, however. So if someone has had surgery for prostate cancer with a prostatectomy or even radiation therapy, and that if either one of those is the cause for their erectile dysfunction and they've lost their ejaculatory function, it doesn't bring back ejaculatory function. So really it is a surgical procedure, though, and with a surgical procedure, you have the recovery after surgery. So typically we put these in and you're uncomfortable for a few weeks while you're recovering. So I don't have patients learn to use it after surgery for about a month, where we teach you in the office how to pump it up and deflate it. So we'll play this video and just kind of, we talked briefly about it, but I'll also kind of talk through the video. So in the penis, there are cylinders. Those cylinders are what fill with fluid. So when you pump up the device, the fluid flows from the reservoir that typically is placed either one of two places. It's either placed in the pelvis, right behind the pubic bone, or in the abdominal wall underneath the muscle, so you don't feel it. And so the fluid pumps into the cylinders to inflate the cylinders. When you're done having sex or masturbating, you press the button to deflate it, and we teach you how to deflate it down. It's that simple. So we definitely know the benefits to having a penile prosthesis placed from a surgical perspective. That's easy. There are always risks that we have to talk about with patients in the office. And the biggest one I tell all my patients is a risk of infection, which is low, but it is not zero. And so the risk of infection is about 2.5%. That is improved in this day and age with antibiotic impregnated devices that we put in to help improve implant infections. However, as a surgeon, my biggest concern for a patient is the last thing I would ever want someone to have is an infection. So that's something I talk to all patients about. You can't actually have a penile prosthesis placed and then go back to a different option. So I tell patients if their erections work fine with pills, don't skip onto doing a penile prosthesis early, because you can't do a penile prosthesis and then go back to using medications such as either injections or the pills. Really, unfortunately, insurance coverage does vary. Most insurance companies do cover surgery for erectile dysfunction, including prostheses. However, not all do. And I also tell patients that these are, if you want to think about it like a car, it is a mechanical device. It's not electronic, but it's a mechanical device. And you should expect to get, I've seen prostheses that were placed 20 years ago that are still functioning. However, I tell patients you get about 10 to 15 years out of them, and then may need to consider having a revision or replacement. So there are certain patients that are at higher risk for infection or infectious complications. Those are patients that have diabetes or spinal cord injury or known open sores. And so those are patients that are at higher risk that really need to know about those risks before they undergo surgery. So those are the biggest complications that I tell patients in the office, or things to think about prior to undergoing any surgical intervention. So as far as implants go, there's lots of information online. There are lots of videos online. You can pretty much find anything on YouTube these days. And so I think it's always important to speak with, get your information from a good source, but talk to your urologist about an implant if you feel like that's the next step for you, or any of the medication options as well. I think I really recommend patients really try to exhaust medication options prior to undergoing surgical intervention. But even if medications don't work, we have options to correct erectile dysfunction.
And this brings us to our sponsor slide. This webinar is sponsored by Boston Scientific, so we'd like to thank them for making this possible tonight.
So as far as injections go, the vials, it typically comes in a vial similar or looking similar to this, and when it shows up in the mail, the compounding pharmacy typically send you the vial, send you the needles as well, and some alcohol swabs. So drawing up the medication, you alcohol swab the top, and then the needles are tiny. They're very, very small, so sometimes it's not easy to see, but I have patients, and we teach patients in the office. The most common volume that we start with is about 0.3 of a milliliter. And so I have patients start with how much they're going to want. They push a little bit of air in and then draw back the amount of medication that they want, which in this case we'd say is about 0.3 of a milliliter. Or if it's an insulin syringe, that's 30 units. So 0.3 or 30 units. And then you have your medication. I have a model here that shows you, so with the penis, there are certain areas that you want to inject. There are certain areas you need to stay away from. All right, let me show you these before we do any injecting. So with this penis, you never want to inject on the bottom of the penis. This is where the urethra is. We stay away from the urethra with any injecting. Alternatively, you don't want to go straight in from the top. Okay? The best way to do an injection is coming in from the side, almost like a 45-degree angle. And you want to inject into the shaft of the penis. So 45-degree angle directly into the shaft of the penis. I'm going to do this injection. So you do a quick swab with an alcohol swab, okay? And then you push the needle in, inject the medication. Once the medication is in, you put a little bit of pressure on the penis, hold pressure for 30 seconds, and that should be good, okay? Takes about 10 minutes to get a good erection. It does, technically this medication doesn't even, or a couple of the medications don't necessarily need sexual stimulation, but it works best with sexual stimulation. So most patients, I tell them, take a little bit of time, talk to your partner, your significant other, let them know you're going to do an injection, and then start foreplay 5 minutes later or so. Gives you a little bit of time for foreplay, and then you should be good to go, usually about 10 to 15 minutes after the injection. With the penile prosthesis, I have a model to show you as far as penile prosthesis goes as well. These look scary outside the body. I tell my patients I don't always like to show them exactly what it looks like on the outside of the body. The videos are better, but on the outside of the body, this is everything that's on the inside. And a lot of guys think, how can all of this go inside of me? The penile prosthesis surgery is performed through an incision about this long on the scrotum. So there aren't any incisions that are on the penis necessarily. The surgery is almost always done through an incision on the scrotum. So the cylinders are in the penis. This pump is in the scrotum, and then the fluid reservoir is in the what we call the space of Retzius, right behind the pubic bone or in the abdominal wall. And when you want it deflated, I'll deflate it real quick. This is just filled with air, so it's kind of flimsy and floppy. But it's deflated on down, and then when you're ready to have an erection, have intercourse, or masturbate, you just pump the pump until it pumps up, and then once it's pumped up and filled with fluid, it's rock hard. So
we're going to hop into the questions. We're going to start off with some general ED questions here. So first question here is, can diet and exercise improve the effectiveness of some of the ED medications we covered tonight?
Yes, absolutely. So diet and exercise can do a number of different things. One of the most important ones is weight loss can help improve exercise tolerance, libido, and increase your testosterone levels as well. So diet and exercise can absolutely help.
Alrighty. Next question here. Can I use Trimix injection one day and the next day use Viagra?
Yeah, you absolutely can. So you can I tell my patients that you can do Trimix on a daily basis. I don't recommend that patients give themselves a second injection the same day, but you can do Trimix one day, you can do sildenafil the next. Most guys that have erectile dysfunction that's so bad that they need Trimix really don't get very good erections with sildenafil anyway. So most of those guys, number one, won't get that good erection with the sildenafil, or number two, and this may be what someone may have, erectile dysfunction can also be partially psychogenic. Doesn't mean you necessarily have to have a problem with your penis, but we are all designed to run away from tigers in the jungle, and the fight or flight response prevents you from having an erection. And so if you have any anxiety over your erections, if you are worried about your erection at all, you kind of activate your nervous system and you can kill your erection. Like if you're ever having sex and you think, is my erection good enough? It really makes it hard to get an erection. So if sildenafil works one day, but you need injections the next day, it may not be just a problem with the penis. There might be some aspect of psychogenic erectile dysfunction.
Alrighty, great. Next question here. Do ED meds have a negative impact on patients with AFib?
No, the erectile dysfunction medications can be used, and you do have to be careful with some of the oral agents. It's not very common that any of the injection agents cause systemic side effects, but the oral agents can cause blood pressure changes. And so patients with AFib that's stable and medication controlled usually don't have any problems at all. But you definitely want to speak with your cardiologist beforehand.
Alrighty. Next question here. What are the best treatment options for ED caused by venous leakage?
So there are a few different options you can consider. You can try intracavernosal injections. However, with venous leakage, unfortunately, you get the blood flow in, you just unfortunately can't keep it in. So some patients will do injections followed by using a silicone ring, kind of like we use for the vacuum pump. They can try injection, they can just try a vacuum pump, or those patients need to go on to a penile prosthesis. What we'll do in the office to diagnose someone with venous leakage is do what's called a Doppler study. In the Doppler study, patient comes in the office, we give them an injection of Trimix, And in the office, we look at the blood flow in the penis. I tell patients that it can sometimes be helpful, and honestly, not always, because even if we do a Doppler study to find out the problem or what the issue is, the treatment is usually my practice about the same, right? We try pills, we may try the gel if they want, or then the injections, and we still do a stepwise approach before I recommend anybody goes on to surgery. However, really unfortunately, if you have significant venous leakage, in the end, most patients have the most satisfaction going on and having a penile prosthesis placed.
Alrighty. Next question here in the general ED section, saw this one more than once. People are wondering if excessive porn watching can lead to erectile dysfunction or any other type of ailment.
It actually goes into partly the psychogenic nature of erectile function. So my answer, short and sweet, is no. It doesn't cause changes or problems with your penis. And most of the erectile dysfunction we're talking about are patients with penile problems. However, porn in general does unfortunately give men an unrealistic viewpoint on sexual activity, both sexual interaction and for penile length, girth, and length of sexual activity. So, number one, all of the guys that you see on pornography are using intracavernosal injection to give them an erection that is as firm as they can get and lasts for at least an hour to 3 hours for them to do enough filming. On the filming as well, when these guys orgasm and ejaculate, they actually will cut that out if it happens early, and then they've already got the intracavernosal injection on board where they can continue having sex, and they just cut out where they lost their erection. On average, people have sex, there are studies that show that average sexual activity is somewhere between 4 and 7 minutes, and so people having sex, all over different parts of the house is not typical for 45 minutes to an hour at a time. So unfortunately, pornography gives unrealistic expectations for men, and because of that, unfortunately, can lead to mental worrying about their erections and the whole psychogenic erectile dysfunction.
Certainly. All answered. Alrighty, next question here. This one is about intraurethral gel. This person says, or they'd like to know rather, how do they keep the gel from coming out when they are trying to put it in? They usually are able to get about 75% to stay in the urethra, and the rest will come out.
Yeah, that's the most important thing, and it can be hard, and some will leak out as long as you get the majority in. So when you're starting, for the one that I use, the compounded medication I use, you're usually using about half of a milliliter of medication or so. And so you push it in, and then it is right as you pull out the introducer, the syringe for it, you have to squeeze the tip of the penis. And it's so important to massage the medication down the urethra. Remember, urethra is on the bottom of the penis. So massaging the bottom of the penis from the tip down so that you get it into the penis. And some will eventually leak out, but really you just need to massage it in and up into the penis as much as possible. If some leaks out, it's not the end of the world. But it's the guys that will just push it in and then take out the little plunger and just let it continue to leak out. They don't get any response from it. So,
alrighty. Next question here. What can be done for patients who have ED after a prostatectomy with no other ED treatments currently working?
Yeah, if you've exhausted all available treatment options, then a penile prosthesis is your option. And there are different available prostheses. Typically, the 3-piece penile prosthesis, the one that I discussed or showed the pictures of, is the best option for the most natural erection. And that means, when I say natural, I mean an erection that is deflated when you want it deflated, and then pumped up and rock hard when you want it inflated. It is not uncommon, unfortunately, that surgery we do for prostate cancer leads to erectile dysfunction. We try to spare the nerves as frequently as we can, but that doesn't always work. And sometimes we can't spare the nerves because we're there to treat prostate cancer. So really the best option for anybody after surgery that has tried other available options or penile rehab, the best option at that point is to consider surgical intervention. So, and with the penile prosthesis.
Alrighty, certainly. That leads us to our next grouping of questions. These are going to be some ICI focused questions. So first one here is quad mix stronger than trimix?
Quad mix is stronger than trimix. It has the addition of atropine, which can help. And so we offer it to patients that have pretty much, I typically in my practice go from, I don't actually use much bimix unless patients have pain with trimix, because some patients don't have pain in the penis. So it's pretty rare that I personally use bimix. Most patients are fine with trimix, and we titrate them up based on different levels. And this is a personal opinion, different people. I tend to find that once patients have maxed out on trimix, they, rather than trying more to going to quad mix, they end up going on and we end up doing a penile prosthesis. But yes, quad mix is a bit stronger, works with a little bit different mechanism by adding the atropine, and can be titrated to help guys for sure.
Awesome. Just a follow-up question to that one right there. So can you elaborate a little more on the medicine and trimix that is going to cause some pain for some patients that is not in bimix?
Yeah, so you've got you've got phentolamine and you've got your prostaglandin. So bottom line, it just, everyone's different, honestly, is what I tell patients. And so it's a trial and error. So you've got your phentolamine, your prostaglandin, and oh my God, phentolamine, prostaglandin, or your
Prostadil is the difference.
Yeah, prostadil is prostaglandin, totally blanking on our third. But bottom line, some patients do have pain with bimix, unfortunately. So I bump them back down to bimix. They usually have improvement in that pain.
Alrighty. Good there. So next question here is, this person says they often experience a bent needle when injecting. Would an auto injector help this process?
They can definitely try an auto injector. Auto injector I found works best for patients that just have trouble with that, like injecting themselves, because with injections, you want to be definitive when you put the needle in, and it is scary to do that. So auto injection usually works best for patients that have trouble committing to putting the needle in. You really just want to put the needle in. You don't want to just kind of poke around trying to make your decision. And so they can always try an auto injector. They may already have some aspect of penile fibrosis there that causes the needle to bend. So it's something that they can try. But a lot of guys have Peyronie's disease as well. And Peyronie's disease can not only cause problems with penetrating, it can cause erectile dysfunction because you may lose some of the veno-occlusive aspect of the erection. And so those patients, they can try different things, but a penile prosthesis will fix both the curvature from Peyronie's disease and the erectile dysfunction.
Alrighty, next question here. It is difficult to inject with shaky hands. Any solutions or tips?
Yeah, I have about a fifth of guys that actually have their partner or their wives do the injection for them. So that works really, really well. Unfortunately, it can be a real challenge. And those patients that have an intention tremor or can't give themselves an injection really are just not great candidates to do injections and do well with prosthesis placement. So you aren't forced to do injections if you can't administer the actual injection. But a lot of guys will have their significant others do it, and that works pretty well.
Alrighty, that's a great solution there. Next question here, saw this one again multiple times. If you're not sexually active right now, is there any need to use the injections?
No, I mean, you don't have to use them. It's really if you want to use them, right? We have medications and we have surgery that can fix your erectile dysfunction. But if you're not sexually active, you don't have to be. Alternatively, there's no age where you have to stop being sexually active. The oldest patient I've placed a penile prosthesis in was 93 years old. And he and his wife were still sexually active. He failed injections. He was actually doing them for about 10 years, and they weren't working anymore. And he wanted a prosthesis. So there's no age where you have to stop sexual activity. I just feel like patients that come in that tell me they're 60 years old or 70 years old and they they want to let it go. That's fine if that's up to them, but they don't need to do it just because they have erectile dysfunction.
Alrighty. Another question that came up multiple times is combining ICI with other modalities. So is it advisable to use ICI with the combination of PDE5s?
No, I don't recommend patients do it. Technically you can, I do have patients that do it, but the medications that are in trimix are function and block the phosphodiesterase, they are phosphodiesterase inhibitors. So you're actually injecting medication directly into the penis, and you don't or shouldn't need to add pills. I have plenty of patients that do add a constriction band, like a silicone ring that you can get on Amazon, or that comes with a vacuum erection device after they've done their injections. Now, you want to make sure that I would give it time to get as much blood flow in beforehand as you can, then you put the silicone ring on. But that's definitely an option. But I personally don't recommend patients take the oral PDE5s and injections at the same time.
Alrighty. Let's go on to some implant questions, and then once we run through these, we can circle back to some other ones in the other groups. But start off with the implant questions. What are some questions that should be asked when looking for a surgeon to do your implant surgery?
So I think one of the most important ones is expertise, how long someone's been doing it. And you want someone that feels comfortable with implants. There are numerous places and people throughout the country. You can get them done in every state in this country. And so comfort and surgical expertise is very important. Now, revision cases, if somebody has a penile prosthesis that isn't working anymore, or they've had an infection in the past, the complex procedures, you really want them done by somebody that is specialized in revision procedures. So, but I'd say really talking to your urologist, making sure that they have done a number of them and feel comfortable is very important.
Alrighty. Before receiving a penile implant, would it be best to use a traction device to increase the penile length?
So patients, there have been numerous studies on this, and you can always try. However, what I tell patients is that it is important to know we place the longest size device that we can place at the time of your surgery. So when we put in a device, we don't check beforehand and say, hey, this is what we think we're going to put in. It's not a small, medium, or large. These penile prostheses are sized to the centimeter on the length, and the length of the penis is determined with a measuring device during surgery. So you're asleep. This surgery, I should have mentioned, takes about 45 minutes to do. So you're asleep for 45 minutes to do the surgery. And we measure the entire length of the penis and size the prosthesis to within a centimeter. And we put in the largest prosthesis that we can absolutely fit to within a centimeter of the penile length.
Alrighty, awesome. Next question here. This person wants to know if there's any risk of losing sensitivity in the penis or the ability to achieve an orgasm.
Excellent question. So no. So the incision for the penile prosthesis surgery is made on the scrotum. However, all the nerves for penile sensation run through a neurovascular bundle that really is on the back side of the penis. And so we aren't near any of the nerves at the time of surgery. We're on different sides of the penis pretty much. And so you have normal penile sensation and normal orgasm afterwards.
Awesome. Next question here. Is the device uncomfortable when not in use?
No, so it's not expected to be uncomfortable when not in use. The first few times you pump it up and are using it can be a bit uncomfortable. So when you're in the recovery phase, we leave, or at least I leave the device partially inflated while you're healing, because it kind of heals with a bit of a capsule around it. And if you leave it inflated, it kind of heals with an inflated capsule. If you left it completely deflated as soon as you put one in, then you can have more discomfort for a while afterwards as things stretch out when you pump it up, because they inflate and they also elongate a little bit after pumping them up. And so, no, they do not typically cause pain in the deflated state, but can be a bit uncomfortable for the first few times when you inflate.
Yeah, I can imagine that would take some getting used to. Alrighty, next question here. Does a penile implant adversely affect urination by any chance?
No, it doesn't adversely affect urination. You aren't expected to notice any change or difference in your urination after one's put in place.
Sweet. Next question here. Is there any way to regain lost length related to Peyronie's disease with an implant?
So some patients do regain length. It's very dependent on how bad the Peyronie's disease is. And so oftentimes, if someone has significant amount of plaque beforehand, we actually will do Xiaflex injections first to try to break up that plaque, followed by the penile implant. And I think one of the best ways to know about the length someone will have at prosthesis placement is taking the head of the penis and stretching it away from your body as far as you can. That really shows the stretched penile length that you can get and what we can give patients from surgery. However, I tell all my patients, your stretched penile length is really what you have. We cannot give you more length, and I can't give a guy a penis that's 2 feet long that they can throw out the window while they're driving down the road. It's just not realistic. And so it's very important to know that your stretched penile length is really what you're working with now. We can always try, if someone does have significant fibrosis from Peyronie's disease, we can try injections to try to break up some of the scar tissue that's there. But we have to have realistic expectations what we can do for patients.
Certainly. Next question here. When using an implant, is it necessary to take PDE5s to help arouse the head of the penis?
No, so it's not necessary. Some patients do use PDE5s and can use it. It's not a problem at all. You cannot do injections once you have had a penile prosthesis placed. So no injections at all should be anywhere near the penile prosthesis. But some patients do notice that they get some more engorgement in the head of the penis when they take PDE5 inhibitors. So they absolutely can use it if they like.
Awesome. Next question here. Is there any way that a penile implant would be able to help with urinary incontinence?
So for the aspects of this talk, my answer has got to be no. Although there are some things, there are some times if someone has had a sling in place or a couple of little maneuvers that can be done where it can help. But for this talk, we say that no, a penile prosthesis is not expected to change incontinence at all.
Alrighty. Saw this one a couple times, so I thought I'd ask it again. But what are some of the long-term risks that you'll see with an implant? I know we already covered them, but
yeah. So the biggest long-term risk patients need to know, or honestly, the biggest short-term risk is the risk of infection. Once penile prosthesis is in, long-term risk is really just device malfunction. And so, because these do have kind of an expected lifespan, and I tell patients that's somewhere around 8 to 15 years. And so if it stops working and it needs to be fixed, then it unfortunately commits you to a second surgery where we have to put you to sleep, take out the old one, we wash you out, and put in a brand new one. It still only takes typically about 45 minutes to an hour procedure, but if you have a malfunction, unfortunately, you have to do that. There are other rare things that can happen. I tell patients about where if you leave it inflated, so it should stay deflated if you are not using it. If you leave it inflated at all times, because the implant does gain some length when you pump it up, it can put pressure inside the penis, and you can get what's called an erosion. And so I tell patients that long term, if you do not deflate it down, it can cause an erosion because it does gain length when you pump it up. And so that would be the worst long-term complication if they left it inflated at all times.
Alrighty. Next question here I thought was pretty interesting. Is there any advancements planned to make the implants inflate from a remote control or phone app, I guess, rather than the button that's currently implanted in the scrotum?
I do not know if I currently am at liberty to say. I can say that that's something that is in the works.
Wow, that's pretty cool.
But I don't know that it's not commercially available yet, and they're working on it. They're working on it. I think that's all I can say.
What course of action would a patient have if they happen to be unsatisfied with their implant?
So it really depends why someone's unsatisfied. And there are a number of different options if someone's unsatisfied. However, I would personally say that in practice, once we've worked through the different options on, is it a problem feeling the device and pumping it up themselves, or the issues with deflating, if it's pain associated, where's the pain coming from? Often when that happens, and it is not common, sometimes it involves a revision where we have to take it out and put a new one in. That usually fixes the issue. It just depends where they're having that issue or why they aren't satisfied. So it becomes a bit nuanced when it comes to that issue, unfortunately.
Sure, that's different patient to patient. So we're going to circle back around to some general ICI questions here. Saw this one more than once. Injection therapy, it can cause scar tissue. So what are some of the ways that can be avoided or eliminated?
So when you're doing your injections, I try to have people use their dominant hand to start out. But once you've been doing injections for a little while, and it doesn't really take that long to learn, usually people can become facile on both sides. And so I recommend rotating different areas along the shaft of the penis rather than always going to the same spot. You do not inject into the head of the penis. You don't inject into the bottom of the penis, we were saying, but really you can use both sides because the corpora cavernosa, the erectile tissue in the penis, is on both sides of the penis and they communicate. So you can use right side, left side, and rotating different locations is typically best.
Alrighty. Another ICI question here. I believe this is venous leak related, but this person says they noticed that lying down following a trimix injection significantly decreases the rigidity of their erection. What may be causing this?
And most guys actually get best if they are standing up. And so really it's gravity related and maybe associated with some venous leak, but most guys notice if they just give themselves an injection and sit down or lay down, it doesn't work as well, or they don't get as good a response as if they are standing up. And really it's gravity. So gravity's helping the medication do what it's supposed to do. So I recommend staying upright afterwards for a little bit. Always hold some pressure right after the injection for 30 to 60 seconds. But after that, it's best to be up walking around for the next 5 or 10 minutes.
Alrighty, we got another implant question here. So does having an implant cause any complications to possible future prostatectomies?
No. And so if you have a penile implant in place, depending on where the reservoir is, it can change a little bit of the surgical approach. If the surgical approach is done with what's called a Retsia sparing technique, that's an approach from actually say behind the bladder and prostate, then it causes no difference at all. If it's a more traditional robotic prostatectomy, what we call a robotic radical retropubic prostatectomy, then the reservoir is usually seen, but it's usually encapsulated and not really within the field.
Alrighty. No, we already answered this one, but I saw it come up again, so I think we should ask it one more time. How long after the implant can one have sex?
The soonest I have patients learn in the office how to use it is 1 month. And technically you can do it as soon as you are not in discomfort. But I have patients, I saw 2 people today in the office back 1 month afterwards to teach them how to inflate and deflate. So 1 month is when I teach patients to inflate and deflate. I also tell patients, after 1 month of surgery, they may still have a little bit too much discomfort. I mean, they feel good after surgery, but it's still a little bit too much discomfort to actually have intercourse or masturbate yet. But I still teach them how to inflate and deflate at 1 month. So that's kind of the expectation.
All righty. Got time for about 1 or 2 more questions. So next question here. Can I use the injection therapy and a VED pump at the same time, or one after the other?
Yeah, absolutely. And so you inject first. So you do intracavernosal injection first, and then I would give that some time, and then you can try to use the VED pump to try to get extra blood flow in. I have a number of guys that do that all the time. And then once you have as much blood flow as you want or can get in there, you put the constriction band to the silicone band around the base of the penis, and patients do great with that.
Alrighty, we got time for just one more quick follow-up question. So when you're using a penile constriction ring and ICI, are you supposed to put the ring on prior to the injection or following the injection?
No, following the injection. So do your injection first, and then put the band on later.
Alrighty. Well, that brings us to the end of our event. So I appreciate you taking the time to answer those questions. We're just going to go ahead and read off our remarks. If you'd like to learn more about ED, you have a few options. There will be more resources in the Resource Center on menmd.com. You can visit this page to view instructional videos, guides, expert articles, and more. You can also call MenMD at 857-233-5837 or log into the MenMD portal to schedule an appointment with a MenMD personal health assistant. If you'd like to compare any of the treatment options that we just discussed on tonight's event, you can do this by going to menmd.com, navigating to our erectile dysfunction condition page, and then scrolling down to the treatment section where you can select up to 3 ED treatments to compare. And finally, you can learn more about penile implants and insurance coverage by visiting edcure.org.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.